Bismillahirrahmanirrahim. What if the day is you are so focused on the future that you don't realize today was what you paid for years ago? My name is Dr. Amna Khalid. I will be presenting the topic of meta-analysis under the kind supervision of Professor Dr. Saida Afsal, who is Dean Institute of Public Health, Lahore. Learning objectives for today's presentation are: we will define meta-analysis, explain steps involved in conducting a meta-analysis, sorry, interpret forest plot and funnel plot accurately, understand the heterogeneity and how to measure it, differentiate different models of meta-analysis, evaluate the strengths and limitations, how to critically appraise a published meta-analysis, and then we will do the practice of MCQs. So a meta-analysis is a statistical technique that combines quantitative results from multiple independent studies addressing the same research question to produce a single pooled estimate. So it benefits in various ways. It combines small studies for greater precision, reconciles contradictory findings across studies, uh, identifies effects invisible in individual trials, and it's on the top of the evidence hierarchy pyramid. So this is the hierarchy of evidence, and you can see that systematic reviews and meta-analysis are at the top. So if we talk about the difference between systematic review and meta-analysis, then systematic review is a structured review of literature, and meta-analysis is a statistical synthesis of results. Systematic review may be qualitative or quantitative, but meta-analysis is always quantitative. Systematic review can exist without meta-analysis, and meta-analysis usually follows systematic review. Systematic review summarizes and critically evaluates the evidence, but meta-analysis produces a pooled effect estimate. Systematic review is a narrative synthesis, and in meta-analysis, we require statistical homogeneity. So every meta-analysis is basically based on a systematic review, but obviously not every systematic review includes a meta-analysis. So these are the types of meta-analysis on the basis of data. We can divide it into the aggregate data and individual participant data. In aggregate data, we use summary statistics from publications, and the effect sizes are used like odds ratio, relative risk, mean difference, and this is the most common type. And in this, we take the raw patient data, which is usually unavailable. In the individual participant data, we have original data sets from investigators. This is the most accurate form, and it provides uniform analysis, and it provides a better subgroup analysis, but it's expensive and time consuming. On the basis of models, we can classify it into the fixed effect model and the random effects model. In fixed effect model, one single true effect is assumed. Differences are due to random error only, and narrow confidence intervals are taken, and less heterogeneity is required. While in the random effect model, true effect varies among the studies, and we account for between study variations. Wider confidence interval is taken, and this is the most common in medical research. So these are the steps in conducting a meta-analysis. First of all, we have to formulate a research question on the basis of PICO framework. Then we develop and register the protocol on Prospero. Then we have a comprehensive literature review. Then the study selection and screening, data extraction, then the risk of bias assessment. Then we calculate the effect sizes. We then assess the heterogeneity. Then we pool the results, evaluate the publication bias, and then we interpret and report findings. Now we will go through the detail of each step. So formulating the research question. This is based on the PICO framework, where P is population, means who are the subjects of interest. For example, we take adults with cardiovascular risk factors. Then I is for intervention, means what is the exposure or treatment. For example, we take statin therapy as intervention. Then on the third number, we have comparison, means what is the control or alternative we are providing. Means, for example, we take another group where placebo is used or no treatment is given to that group. And the fourth number, we have outcome, means what is being measured. For example, we are measuring cardiovascular mortality among such adults. So the example will of the research question will be, does aspirin reduce cardiovascular mortality compared with placebo among adults? So after this step, we have to develop the protocol. Protocol is has to be well defined, and it is the foundation of a rigorous meta-analysis. So in the protocol, we include objectives, which should be clear in research question based on the PICO framework. Then the eligibility criteria. We have to mention the inclusion and exclusion criteria. Then the databases which will be used, like PubMed, Embase, and so on. Then the search strategy, like the keywords or the match terms which are being used, Boolean operators which are being applied, and then we have to define the outcomes, which should be primary and secondary outcomes, and they should be properly specified. Then we have to mention the statistical methods which will be applied, like which model we are using, fixed or random, and the heterogeneity test which will be applied. So all of these has to be mentioned in the protocol. So the purpose of protocol is that it reduces the bias and increases transparency. So we have to register before data collection begins. For protocol registration, Prospero is the registry, which is the international prospective register of systematic reviews, and this is hosted by the University of New York's Center for Reviews and Dissemination (CRD). Free system registration for systematic reviews in health-related topics is available. So the purpose of registration is that it prevents the duplication, allows the researchers to identify ongoing reviews on similar topics. Then it provides the transparency protocol registered before data extraction begins. And then it reduces the selective reporting. Pre-specified outcomes prevent the outcome reporting bias. So after registration is approved, then we start with the literature search. We use different databases. The key databases are PubMed, Embase, Cochrane, Scopus, Web of Science, and there are many more. That also depends on the topic we are doing meta-analysis on. So then we have the Prisma flow diagram. In that we first of all mention the records which are identified. We mention their number. Then we mention the duplicates which are removed. Then we mention the titles or abstract which are screened, and we are left with how much number. Then we mention the number of the articles for which we are doing full text assessment, and then at the end we mention the number of the studies which are included finally. So Prisma stands for preferred reporting items for systematic reviews and meta-analysis. So we have to then mention the inclusion criteria. The criteria must be established before searching begins. In inclusion criteria, we can mention the study designs, which study design we are taking, our city cohort, and so on. The population we are taking, for example, the age group, the disease status of the people, demographic characteristics. We can mention the intervention, like what will be the type of intervention, dose of any medicine, duration of the treatment, route of administration. Then in the comparator, we can take the placebo, standard care, or alternative treatment. In outcomes, we take primary and secondary outcomes of interest, and those outcomes must be measurable. In language, we can include English only or all languages with translation, and we can also mention publication years in the including criteria, that the date range for included studies. Excluding criteria reduces the noise by eliminating the studies that do not fit the research question. For example, we can exclude the animal studies, we can exclude duplicate publications or incomplete records or irrelevant outcomes or poor quality studies. So Prisma statement, as I already told about it, this includes 27 items checklist plus a flow diagram for transparent reporting. And it was originally published in 2009 and then updated to the Prisma to 2020. This is endorsed by major journals and funding bodies worldwide. The advantages of Prisma statement is that it has the completeness, ensures all key elements of the review which are to be reported. The transparency, Readers can assess methodology and reproducibility. Third one is reproducibility. Detailed methods allow replication by other researchers as well. Then the journal compliance. This is required by the top journals like Lancet, VMJ, JAMA, and so on. So this is the Prisma flow diagram. We have already gone through it. Then after the process of screening, we have to do the data extraction. This is conducted by independently by two reviewers. So discrepancies are resolved by consensus by the reviewers. In the data extraction, the main things we include are first one is the author. We mentioned the first author, the year of publication, and the journal in which the article is published. Then the year of publication year and the country where it is published or the study is done, the study design, then the sample size. We can also take the total sample size or the sample size of intervention and control group. And then the outcomes, the reported outcomes which are measured has to be mentioned in one column, and then the effect sizes and different forms, whatever the effect sizes are measured in the form of odds ratio, relative risk, mean difference, and so on. Then we go for the risk of bias assessment. The purpose of this is we have to determine the internal validity of included studies and assess the confidence intervals. For the risk of bias assessment, we take different tools. For example, we can take Cochrane risk of bias tool, ROB2, which is mainly used for RCTs. The key domain is we assess the randomization process, deviations from the interventions, if there are any, the missing outcome data, measurement of outcome, how it is done, and the selection of reported results. Then we have Newcastle-Ottawa scale. This is mainly used for observational studies like cohort and case control studies. The key domains are we assess the selection criteria, comparability, and the exposure or outcome. Then we have Robbins 1, which is mainly used for non-randomized studies of intervention. The key domains which are assessed in Robbins 1 are confounding, selection of participants, classification of interventions, deviations from the protocols, and missing data, measurement, and reporting. So these are based on the type of the study design. Now we have included in our final selection, and then we apply the scale or tool accordingly for the risk of bias assessment. After this step, we then move to the effect size measurement. Effect sizes are different, like in case control studies, we can have odds ratio. So if it is equal to 1, then the effect is 0 means there is no effect. If it is more than 1, we have increased odds, and if it is less than 1, then it is the a protective factor. And then if we have a relative risk, mean we can have it in the cohort studies or the clinical trials. Again, equal to 1, no effect; more than 1, increased risk; and less than 1, reduced risk. Hazard ratio, which we take in the survival at a time to event analysis. This is interpreted similarly in the form of as we did in the relative risk, and it accounts for the time basically. Then we have mean difference, same scale outcomes. For example, if we are taking the blood pressure, so absolute difference between group means is measured in the form of mean difference. Then we have standard mean difference. If we take different scales, for example, in the form of depression, this is the example. So this is standardized. If the value is 0.2, then the standard mean difference is small. If it is 0.5, this is medium. And if it is 0.8, then it is large. So after the effect size measurement, as we talked about that, we used one of the model, the fixed effect model and the random effect model. So in the fixed effect model, again, we assume one true underlying effect, and all studies estimate the same true effect. Differences arise from the random sampling error only. This is appropriate when studies are homogeneous, and it gives greater weight to larger studies and produces narrower confidence intervals. But if we take the random effect model, this assumes different true effects per study. True effect varies between studies. accounts for within study and between study variation used when heterogeneity is present. We will talk about it in the next slides as well. More balanced weighting across studies is present, and it produces wider confidence intervals. So here we come to the heterogeneity, which is the variation in study results beyond what is expected by chance alone. So the heterogeneity can be due to the clinical things like age, sex, or disease severity, comorbidities, or ethnicity. Then the methodological, the study design, follow-up duration, outcome definition, or bias if any present. Statistical methods like random sampling variation and chance differences. These are the tests which are used to measure if heterogeneity is present or not. So Cochrane's Q test is these are the tests whether observed variation in study results exceeds what is expected by chance alone. So Cochrane test, Q test, if the p-value is less than 0.05, this indicates significant heterogeneity. So you can see the formula on the screen, and then we have mentioned that W is the weight assigned to each study, and the effects estimate of the study, and the pool effect estimate, and the degrees of freedom, which is the number of the studies minus one. So this is the formula, and ultimately we have to focus on the results and the value which is being provided by this formula. But the limitations of Cochrane's Q test is that low statistical power with few studies and overpowered with many. So this is interpreted alongside the I-square test. So I-square statistic, which is most commonly reported measure of heterogeneity. This quantifies the proportion of variance which is present due to the heterogeneity. So again, its formula is also given, and how it is interpreted. If the a value comes between 0 to 25%, then low heterogeneity is present. Between 25 to 50, moderate heterogeneity. 50 if between 50 to 75, substantial heterogeneity, and if it is more than 75, then considerable heterogeneity is present. So after the assessment of heterogeneity, then we move to the forest plot interpretation. You can see that the effect size of each of the study is mentioned in front of the author names. Uh, each line in this represent one study, means one square is equal to point estimate. The box size is equal to the relative weight of the study, and the horizontal line is the 95% confidence interval. The diamond, although not shown in this picture, shows the pooled effect size, and the confidence interval crossing vertical line is not significant. So after the this step, we move forward to the publication bias and funnel plot. Publication bias occurs when the positive or significant studies are more likely to be published than negative or null results, distorting the pool estimate. Causes of publication bias are that the journals prefer significant findings, or the researcher a selective reporting can be there, language bias is present, or citation bias is present. So this publication bias is assessed by the funnel plot. If the funnel plot asymmetry is present, then we move to the Eggers test or the trim and fill method. So you can see in the picture, in the funnel plot, this symmetric means low bias, and if it is symmetric, then there is possibly bias is present. So these are the advanced methods which are used in the meta-analysis, like subgroup analysis, which explores the heterogeneity by dividing studies into the clinically meaningful subgroups, like according to gender, age group, or country. Then sensitivity analysis, and these are the test robustness by removing low quality or outlier studies, or by changing the statistical model. Then meta-regression, which investigates whether study level covariates and explain the variability in effect sizes. Then the network meta-analysis, which compares the multiple interventions simultaneously using direct and indirect evidence, useful when head-to-head trials are unavailable. Then the Bayesian meta-analysis, this incorporates prior information and probability distributions, increasingly used in modern evidence synthesis. The living meta-analysis, which continuously updated as new studies emerge, and particularly valuable during rapidly evolving situations, for example, pandemics. So the strengths of meta-analysis are that it has the highest level of scientific evidence, increased statistical power and precision, resolves conflicting findings across studies, cost effectiveness versus running new large trials, detects small effects invisible in single studies, and supports clinical guidelines and policy. But the limitations are that it can be like garbage in and garbage out because it depends on the study quality. Publication bias can distort the results. Combining incomparable studies can be present in the meta-analysis. Ignoring substantial heterogeneity can mislead. Risk of selective reporting and outcome bias is there, and time intensive and resource demanding. So for the critical appraisal of meta-analysis, we have some of the questions like, was the research question clearly defined using PICO? Was the protocol registered, for example, in Prospero? Was the literature search comprehensive and reproducible? Were the inclusion and exclusion criteria pre-specified? Was the risk of bias assessed for each study? Was heterogeneity explored and reported? Was publication bias assessed? Are the results clinically meaningful or not just statistically significant? So we take the Prisma 2020 reporting and fill the whole checklist, and then we assess and appraise it. So now we come to MCQs. Question number 1 is, a team reviews all published studies on vitamin D supplementation and fracture prevention. They summarize findings narratively but do not statistically combine results. This study is best described as option A, option A, randomized trial, B, meta-analysis, C, systematic review without meta-analysis, D, ecological study, and E, case series.
C.
Yes, C is the right answer. Question number 2, 5 clinical trials investigating the same intervention show nearly identical results with minimal variability between studies. Which meta-analytic model is most appropriate? Option A, Bayesian model, B, random effects model, C, fixed effect model, D, meta-regression model, and E, network model.
C.
Yes, C is the right answer because same intervention is being used. Option 3, question number 3, a meta-analysis of obesity interventions includes studies from Asia, Europe, and North America. Results vary substantially because of differences in populations and interventions. Which statistical model is most appropriate? Option A, fixed effect model, B, random effect model, C, chi-square test, D, pair t-test, and E, ANOVA.
B.
Yes, now it's B because of a lot of variation. Question number 4, a pooled analysis reports an I-square value of 82%. What is the most appropriate interpretation? Option A, no heterogeneity, B, low heterogeneity, C, moderate, D, considerable heterogeneity, and E, publication bias exist.
E.
D, yes, D is the right answer because the value is more than 75%. Question number 5 is, a forest plot shows a pooled odds ratio of 0.75 with confidence interval 95%, of 0.60 to 0.90 range. What is the correct interpretation? Option A, no significant effect exists. Uh, option B. Option B, treatment significantly reduces risk. Option C, treatment significantly increases risk. D, results are inconclusive. And E, publication bias is present.
B.
Option B is the right answer because odds ratio is less than 1. Question number 6, researchers identify 4,500 articles from databases, then remove duplicates, screen abstracts, assess full text, and finally include 18 studies. Which diagram best presents this process? Option A, funnel plot, B, Kaplan-Meier curve, C, forest plot, D, prisma flow diagram, and E, scatter plot.
D.
D.
Yes,
A.
D is the right answer. Question number 7. A meta-analysis includes only published studies. The investigators suspect that several small negative studies were never published. This concern represents option A, recall bias, B, selection bias, C, information bias, D, publication bias, and E, observer bias.
Publication bias.
D.
Yes, D
D.
is the right answer. Question number 8. A researcher wants to statistically assess funnel plot asymmetry. Which test should be performed? Option A, McNemar test, B, a Cochrane Q test, C, Agar's test, D, Fisher exact test, and E, Wilcoxon test.
B.
Uh, C is the right answer. Although we did not go through the detail of Agar's test, but I mentioned that if we find asymmetry in funnel plot, then we have to move towards the next tests, like Agar's test and treatment funnel method. Question number 9. A meta-analysis includes studies with varying quality. Investigators repeat the analysis after excluding low-quality studies to determine whether conclusions change. This process is called option A, matching, B, sensitivity analysis, C, meta-regression, D, stratification, and E, standardization.
B.
Yes, B is the right answer. This is sensitivity analysis where we remove the low-quality studies. Question number 10. A meta-analysis combines data from studies using different depression rating scales. Which effect measure is most appropriate? Option A, relative risk, B, odds ratio, C, hazards ratio, D, mean difference, and E, standardized mean difference.
E.
Yes, E is the right answer because we are using different scale. So this is the answer key, and this is the YouTube channel of IPH where this presentation will be uploaded. And thank you so much.